hemochromatosis. My lab, when I worked at the National Institutes of Health, my boss, his main research interest was actually beta thalassemia, and also did a lot with sickle cell. So that was pretty interesting. And one of our fellows we had at the time, he, an MD, he was doing a joint fellowship, kind of smart guy, doing a joint fellowship between Hopkins. So his clinical pediatric hematology oncology work was at Hopkins, and all of his lab research was with us. And I emailed him last night, and he sent me some case studies and stuff that I'm going to go through. So that could be pretty interesting, hopefully. So, all right, hemophilia. Every now and then I'm a little bit of a history geek. I like knowing like why we do the things we do and the meanings behind, you know, words and phrases and that kind of stuff. For instance, does everybody know why typically when you, totally off topic, when you sit down, let's say in a chair or a table, if you walk up, you know, you pull out the chair and you sit from the left and you exit from the right? Anybody know why? Okay, this is pretty cool. Because when men wore swords, if ladies sat from this side, they would cut their dress to ribbons on their swords, on the men's swords. So, pretty cool, huh? Now you've learned, you won't remember anything else from today, will you? But you'll remember that story. Okay, so anyway, history of hemophilia. There is written history of people with bleeding disorders all the way back to the 2nd century. It's a long time ago. The first published article, however, was in 1803, which is still pretty cool. That's still several years ago. And it was by John Otto. He was a Philadelphia doctor. And he somehow traced this patient's bleeding disorder all the way back to a female in 1720. So that was obviously long before we had, you know, online genealogy. He had to do quite a bit of digging here. My family sure as heck wouldn't know, but I thought that was pretty interesting. So then in 1813, New England Journal of Medicine had a paper that proposed the disease could actually be genetic and that it could be passed from men to their daughters, and even some of these daughters could be unaffected. So that was obviously long before the advent of molecular biology as well, but I guess Mendel was around and people are starting to thinking about things can be hereditary, things can be passed down. Then in 1828, there were 2 Swiss doctors who had seen this, and they named it hemorrhaphilia. Probably saying that incorrectly, but I'm not going to test you on that word. I just thought it was cool. And of course, we've all heard the, you know, Rasputin stories. And for a long time, especially in Europe, it was called the royal disease. And of course, because there was a lot of consanguinity, a lot of inbreeding, not only amongst themselves, but also within royals of different countries. And so, big surprise, something that is a fairly common genetic disorder is going to get passed down. And they saw this in England, Germany, Russia, and Spain especially. So, how the whole Rasputin story came about is that there's this descendant of Queen Victoria, I think her name was Alex or Alexis or something, it kind of passed on down. And she married Tsar Nicholas of Russia. They had a son, Alexei, who had hemophilia. So they get this Russian mystic Rasputin to come in and help them, and then, you know, we all know in general the family kind of disappeared, was murdered, was not murdered. You know, if you don't know, go watch the Disney movie. But this all happened during the Bolshevik Revolution. So it's well-known disease, obviously. So back in the 1920s, if you were born with hemophilia, your life expectancy was only 13. Not great. And I can imagine if you're running around barefoot, you're probably going to cut yourself, fall out of trees, all that kind of stuff. There aren't any blood transfusions going on. There's no recombinant factor to give you. You're probably not going to make it. By the 1950s, it had risen to about 20 years old. By now, they're starting to talk about blood transfusions, those types of things. By the 1980s, we obviously had a better handle on being able to somewhat treat hemophilia. However, what happened in the 80s, we had HIV. And this was before testing was widely available. So about half of all hemophiliacs in the 80s contracted HIV. So that's pretty tragic. I think probably most of you remember, I think it was the Ryan White story, the young child. I mean, the good thing that came from that, if there is a good spin on that, was it really helped help people understand the progression of the disease and the contraction of the disease, and that it wasn't nearly as easily transmissible as we had thought. And of course, Princess Diana was really instrumental in that as well. Some of you are close enough to my age to remember her and remember her work in that field. It was pretty groundbreaking at the time. So on top of HIV, the other thing was HCV. So hepatitis, unfortunately, was readily passed to these patients as well. About 40% of hemophiliacs also contracted hepatitis C through transfusions. And that testing really didn't become available until about 92. Seems like a long time ago, but that's when I graduated from high school. So it was just, a year or two ago. Also in 92 was when the first recombinant factor 8 was approved by the FDA. And in 97 was the first recombinant factor 9. So that's, pardon.
What?
Huh? Oh, sorry, it should be 8, not 13. Right here. Typo. Okay, in 2013, there are 3 gene therapy trials to deliver factor 9 genes into patients' livers. Factor 9 is much smaller than factor 8, so it was easier for them to try to do that. So they tried it with some viral vectors and other things. My understanding is that they couldn't get enough protein expression to adequately treat the patients. So they'll go back to the drawing board, work on how to actually deliver these factors by gene therapy versus the recombinant protein levels. Okay, so clotting cascade. There's the extrinsic, there's the intrinsic, and there's also the common pathway. I kind of like to think of the extrinsic as the spark, especially if there's trauma. That's typically that side, right? Intrinsic's kind of the workhorse, and they both come together then at the common. Factor 8 and factor 9 are part of the intrinsic pathway. But they all kind of, I'm sure you guys have had this, they all kind of intercorrelate. Okay, I'm gonna go through a brief overview of how all this works. Okay? And this is the level you will need to know this. I'm not gonna go back, I'm sure you've had it, and test you guys on factor 2, hit swear, and fibrinogen, and that's as bad as signal transduction to me. But okay, so like we said, both of these factors are part of the intrinsic pathway. They work together to achieve hemostasis in a patient after there's been some type of injury. Hemostasis, of course, control the bleeding. Okay? You achieve hemostasis by coagulation, which is formation of that fibrin clot. And there's really kind of 4 phases of hemostasis or of coagulation. 1, vascular constriction. stop the bleeding as much as you can, right? Slow it down. 2, you get the platelet activation and the platelet plug, but that's still pretty iffy. But from there you get the clot formation, right? You get the red clot or the white clot. And then of course eventually the clot has to be dissolved to get continued blood flow. Clotting for dummies right there. Another extremely simplified view, but I like this one, because it shows, let's see, intrinsic pathway, extrinsic, common, but this also points out where different tests really come into play. And we're going to talk about that later on in the lecture, but for the most part, your APTT is looking at your intrinsic pathway, and your prothrombin time is looking at your extrinsic pathway. Okay, so the genetics of hemophilia A and B. It's X-linked recessive. Okay, men cannot pass this disease to their sons. Why is that?
That's the Y.
Excellent. Okay. Whew. We didn't know that. We were going to have to start the whole course over. Okay, so men are only passing that Y chromosome to their sons. So an example here is if you have a carrier female, so she's got one affected X, one unaffected X, and she has kids with an unaffected male. Your 4 possibilities that they have offspring are a carrier daughter, right? She got the bad one from the mom, the only one from the dad. So she's carrier. She can be a non-carrier. She can be perfectly fine, right? She can get the good one from the mom and the only one from the dad, which was also good, okay? They can have an affected son, right? Because they got the bad one from the mom and the Y from the dad. So the only one he's got is the bad one from the mom. And they can have a non-affected son. Okay? Good one from the mom, Y from the dad. All right? So that's how that goes. However, 25 to 30% of hemophilia is due to spontaneous mutations. Right? Those somatic mutations, they just happen, something happens, we don't know. And now they have hemophilia, and there's no family history that anybody can see. Which I find kind of interesting, right? Because so many of the diseases we've looked at, like with colon cancer, right, it's like 5% or something is genetic. This is kind of the opposite end of the spectrum. Okay, a lot of times it's due to a missense mutation. And usually those patients have a less severe form of the disease. If the mutation is from a deletion, so they're missing a big chunk, usually your prognosis is poorer because they're more resistant to therapy. Okay, I want to give you guys a side note here, because this really frustrated me. There have been a few times every now and then in your text, I find that they try to oversimplify the molecular explanation of something and wind up getting it actually wrong because they've tried to oversimplify. So there's a statement, and I think it's in the hemochromatosis chapter, and I will say this again there. But the statement in there says something like, a point mutation, something like the amino acid change is because of a point mutation or something like that. I'll point out when we get there, but I just want to make sure that everybody understands you don't always get disease from a point mutation, right? A point mutation is a single mutation. But we know that amino acid is from a 3-letter codon, right? And some of them code for the same things. So a CAG and a CGA, I don't know if that's correct or not, but may code for the same amino acid. So changing one may not necessarily result in disease. So we'll get there, I'll point it out, but sorry, that frustrated me in the text. Okay, so in general, hemophilia affects about 1 in 5,000 live births. It's about 1 in 4,000 males have hemophilia A. And hemophilia B is much more rare. It's only about 1 in 20,000 males. And all this to do, of course, to those different clotting factors, factor 8 and factor 9. So the normal range of that protein activity of those two factors is from 50 to 150%. How you get 150%, I do not know, but that's what they say, and that's what we're going by. So you have 3 categories, whether this is hemophilia A or B. You get 3 categories of disease. You get a mild case, which is about 25% of cases. And they have decent activity levels, 5 to 40%. Moderate is only about 15% of cases, and they're about 1 to 5% range. And here's the unfortunate part, is that severe hemophilia accounts for about 60% of cases. And that's less than 1%, oops, another typo, 1% of the activity range. So here's the thing, these patients may have the factors, right? This doesn't mean that they're not there, but it looks like they don't often work. Okay, so that's why they're measuring activity range. Okay, a little bit more on the categories. So mild, remember, about 25% of cases. A lot of times these patients aren't diagnosed until adulthood. Okay, a lot of times it's not until after they've had some type of injury or surgery or some type of major dental procedure, and wow, they just don't stop bleeding, or they just don't stop oozing. For example, somebody who, let's say, had a cardiac catheterization. So they've just got the puncture, right? They just got a little puncture. And they're holding pressure and holding pressure and holding, and they just keep oozing. Okay, so, they may have never had anything else happen in life to them. Saw a patient in clinic yesterday. He is 78, he has never had surgery before. So getting his heart valve replaced is going to be the very first surgery this poor guy has ever had. It's pretty impressive. In our society, that's making a long time. The other thing for women is that they may experience heavy menstrual bleeding. So that may be for women the tip off. Moderate disease, obviously a little bit more severe, more likely to get bleeding in your joints and your muscles following an injury. Especially some of the bigger joints, knees, elbows, things you're most likely to bang into stuff, especially if you're a child. If you're a parent of a toddler, you know exactly what I'm talking about. Especially when they run into your joints. And in severe, remember, 60% of cases, and these patients, unfortunately, they just spontaneously bleed. And they spontaneously bleed into big areas. Joints, brain, bad stuff. Hemophilia A is also called classic hemophilia. Like we said, it's a mutation in the, big surprise, F8 gene because it encodes factor VIII protein. We are so creative, but same with hemophilia B on the F9 gene because it encodes factor IX. It's also called Christmas disease. A little bit more history here for you. And it's named after Stephen Christmas, who was the very first patient described with this disease. And additionally, it was reported in the Christmas edition of British Medical Journal in 1952. It's much less common than hemophilia A, like we talked about. And again, we talked about how about a 25 to 30% of hemophilia is actually caused by spontaneous mutations. Another phrase for spontaneous mutations, or the very first mutations, are de novo, meaning new. It's the first time it's seen. I love how in your text we're finally on like what, chapter 10 or 11, and they're still just now explaining like the term proband or something.
If someone has a spontaneous mutation for hemophilia, is there a risk that that could affect some cells and they could pass that on, or is it usually kind of more like, all right, it's somatic, that's the only one, you know?
I don't know how often that goes to the germline or not. I think that's probably pretty rare. But obviously it happens because every germline mutation has to start with someone. You know, there's a chicken and there's an egg. Okay, so what do these patients look like when they come in? Okay, let's look at the term variable expressivity. That's the variable severity of symptoms. And we're not going to confuse that with penetrance. So I knew somebody was going to ask me that. Okay, so remember, penetrance is whether you actually develop the disease when you have the mutation. Variable expressivity is a variation of the severity of symptoms. Okay, penetrance is whether you actually manifest disease or not. Variable expressivity is do you have mild, moderate, severe, that type of thing, okay? Some patients have a mild case of something, some patients have a more severe case. That's what that means. Okay, back to our categories. So severe is often diagnosed soon after birth. So these poor babies, I mean, you know, they're being held and they spontaneously bleed, and they're bleeding into their little knees and their ankles, their elbows, and that's got to be pretty sad and extremely frightening. Internal organs most likely affected in these patients all the way through growing up is more likely to have gastrointestinal bleeding. So that comes then. They obviously do not want to bang their heads on anything. Moderate, usually patients are diagnosed before age 6. So, and that's not really surprising, right? They're learning to walk, they're riding bikes, they're doing all those things where they're going to bang something and have some type of injury probably. And then they're going to bleed into one of those joints. And mild, like I said, possibly not diagnosed until adulthood. They just haven't had something major happen. Okay, so the two are clinically indistinguishable. So if you have a patient that comes in and you're suspecting that they have a bleeding disorder, and from the labs you're looking at it's probably hemophilia, you cannot tell from that whether it's A or B. They look exactly the same. Some of the labs that you'll use to confirm hemophilia, however, So you're going to be looking for a prolonged APTT, the activated partial thromboplastin time. But they're going to wind up with a normal prothrombin time. Why is that? If I remember that. Good job. You're also going to have normal fibrinogen levels. They're going to have a normal bleeding time. You're going to need specific factor assays to determine whether it's 8 or 9. Okay, a little bit more about those labs. Like we said, APTT measures your intrinsic pathway. It's much more likely to show up in patients who have moderate to severe cases. In normal people, it's used more likely to monitor heparin therapy. So you're going to look at that on normal people, which obviously you're not going to be giving to your hemophilia patients, but it also helps detect clotting inhibitors. Prothrombin, use that to measure more long-term anticoagulation therapy, like Coumadin. Like I said, neither measure specific factors or inhibitors of those factors, which some patients wind up having. You're also going to get a platelet count because you want to make sure they're not bleeding because they have thrombocytopenia, right? I mean, that'd be a big mess. Oh, you have hemophilia. No, you're just low on platelets. That will not win you points with your patients. Bleeding time, you're going to look at platelet function disorders. So they have plenty of platelets, they're just not working. And that bleeding time is prolonged in, for example, von Willebrand's disease, which we will spend about 30 seconds on at the end here. Okay, so counseling. You suspect this patient has hemophilia. What do you do for them? Well, you actually want to identify the mutation. There's 2 big mutations, but there's a reason for identifying the mutation in these patients. Even if you can't actually treat that specific mutation, it can be correlated with disease severity. So remember the missense versus deletion mutation. Some of the missense mutations have a less severe case of disease, and the deletion has a more severe case. So you actually do identify the mutation. For some reason, you can also predict the development of specific factor inhibitors based on that mutation. I don't know what it's encoding, why it does that, but it just falls in line with this is something you want to do for these patients. You obviously want to take a family history. You want to find out any other patients who have bleeding issues in the family. Probably ask about consanguinity, anything like that. Make sure nobody's related to, Russian royal family. I don't know. They do you have any big diamonds, rubies? Pass them along. Ask about the patient's own bleeding history. Especially if they have a mild case. You may be able to look back and see that there were times, there were hints or signs that something was going on. Obviously, you're going to get the labs. You're going to do a good physical exam. You're going to especially look at the joints, making sure, especially in those moderate to severe cases, that they're not bleeding currently into their joints. And then, of course, if they've had transfusions, especially prior to about 1990, you're going to want to look for other potential diseases. You're going to want to screen them for HIV, hepatitis, those types of things. Unfortunate. mean, you have to assume if they didn't know they had HIV and they contracted in the 80s, they're probably not, they're not still here. But hepatitis, you never know. So what are you going to do for these patients now? Well, the best thing you can do for them really and truly is to refer them to a hemophilia treatment center. These types of centers have big interdisciplinary programs and teams. So they have not only genetic counselors, but they have specialized hematologists, they have research nurses, they have, you know, patients who are following liver function and all kinds of stuff that you're probably just not going to get from your regular primary care physician. Studies have shown that patients who follow with a hemophilia treatment center actually have lower mortality rates. We don't have one here. And in fact, there are only 4 cities in Florida that have one of these. Tampa, Miami, Gainesville, and Jacksonville. There are actually multiple ones in Tampa and Miami, like St. Joe's is one, All Children's, which is technically St. Pete, but close enough. Miami has a couple. So in young children, remember a lot of severe cases are diagnosed right after birth. These patients need to be seen at least every 6 to 12 months. And if these patients have more severe disease and you're actually giving them recombinant factors, you want to see them pretty frequently until they get stabilized on those factors. You don't want to send them home and just hope they're not bleeding and see you in 2 years unless, you know, you hurt yourself. That's not going to go over well. But once you get them stabilized, then it's annually is fine. Mild disease typically can be followed about every 2 to 3 years as long as they're not developing more severe symptoms. And of course, you're going to want to evaluate these patients before any type of surgery or dental procedure. The last place you want to figure this out is, yeah. We actually got a patient one time from a dentist when I worked in neurosurgery. Patient wouldn't stop bleeding from something, and they sent them to us for the neurosurgeons to actually put some stuff in there. Yeah, scary, scary time. I don't think I'd ever want to be in the dentist chair with an ambulance coming for me. And it was not the dentist's fault. It wasn't the patient's fault either, but. Okay, so patients with severe disease are probably going to want to be treated with IV infusions of these recombinant factors, either 8 or 9, based on which disease they have, right? These patients can actually be taught how to administer this to themselves because it really needs to be given within an hour of the onset of bleeding. So either they can be taught how to give themselves this IV transfusion, or if they're a child, you teach a family member. But you know, the last thing you want is if your kid is out playing and they're, you know, at a neighbor's house, by the time you get there and you have to call somebody and get them to a hospital, or if you live out of town or whatever, this is a lot safer. Question?
So are parents taught how to like start an IV line then for the kids?
Apparently so. Yep. Milder disease, these patients can get just factor concentrates or desmopressin, which apparently can actually be administered nasally. That'd be nice. So desmopressin is a hormone which increases factor VIII. Then of course you're going to want to do an entry risk assessment in education. God help you if you're a parent trying to run after a little one who's got this. I would be just give me the IV and a prescription for Xanax and we'll be great, because I would be a wreck running after a baby with this. But on the opposite end of that, you also want to make sure the patient's exercising enough. You want to keep their joints strong and healthy as much as possible, especially if you're looking at bleeding in there. Yes?
It looks like they actually implant ports into kids that have really severe things, so the parents can just poke through and.
Even better. There you go.
I don't know if that helps, but.
Thank you.
Probably bleed without putting it in.
Yeah, exactly. And of course they want to avoid physically risky activities, you know, jumping off the swings, probably gymnastics, contact sports.
No MMA.
This is not when you're going to sign your son up for football. Avoid aspirin and aspirin containing type medicines. If you can avoid surgery, intramuscular injections, and dental procedures. I thought that the IM injections was pretty interesting because, you know, with children, I mean, I would assume that most parents would still probably choose to vaccinate their kids against at least most things. I guess you'd weigh the risk of an IM injection versus not being vaccinated. That's a whole different argument. Okay, von Willebrand's disease. I actually know somebody with this. So it's based on von Willebrand factor, which is either missing or non-functional in these patients. Very differently, this is actually an autosomal dominant disease versus the X-linked recessive for hemophilia, right? Because it's autosomal dominant, is there a difference between males and females contracting the disease? No. Good job. Okay, so, which also makes it the most common heritable bleeding disorder. So it's more prevalent. And that's all we're going to say about that, except for what's in the book. All right, a couple more slides just because I thought these were pretty cool. This was I thought, an interesting slide based on the pathways. But what I wanted to point out here is because obviously at some point you're probably going to have patients who are on some type of anticoagulant therapy. And it dawned on me, because we give our patients, you know, warfarin and heparin and all kinds of stuff. I actually didn't know where they each were activated, so I thought this was pretty cool. So it looks like warfarin can actually inhibit several different factors here for anticoagulation. You got factor 10 inhibitors. Heparin comes here, a thrombin. Thrombin 2A inhibitors, like your Xareltos and stuff, I think. And then down here, your TPA, like for your stroke patients. I don't know, side note, but I thought it was interesting. And then this one has a lot about some of the newer factor 10 inhibitors, right? Like rivaroxaban, Bilarudin, dabigatran, all of those. So when patients can't take warfarin or Coumadin, some of those things. Saw a lady the other day who, you know, chronic AFib, but she's 83, and blind. Do you want to put a patient like that on Coumadin? No. I mean, her risk of falling at that age and causing a subdural and dying from that is so far off the chart. So you're going to use one of these other different types of anticoagulations for a patient like that. Okay. Questions on hemophilia? All right. Okay, guys. I will try to get everybody who emailed me, I'll try to get you back your pedigree in the next couple of days if possible. All right. Thanks, guys.
Thank you.
Yes. Yeah, no. I was on that week, whether that froze me. Order right now. Do you have the app? It takes 2 seconds.